nursing school versus real bedside nursing.
So I always get this question, especially from my new nurses. How did you get to where you are? Or I hear things like it's different nowadays as far as vet nurses helping new nurses. And so let's address the difference of nursing school versus real bedside nursing. As a new grad, let's take it back. Let's take it back before a new grad. In nursing school, during clinical, and I know clinicals are a little different nowadays, but back then, clinicals were a group setting. We went to a hospital, we shadowed a nurse, passed meds, and then we had homework, which would be whatever medications or whatever disease process that you saw, research the medications, figure out their mechanism of action, what they would be used for, how many times a day. And that was really pretty much it. We had care plans and things of that nature, but now I know it's a little different. And I know that when I became an actual bedside nurse, oh my God, I was totally humbled at like how nursing school preps you for the foundation, but it does not prep you for the actual experiences that you're going to get out of nursing, out of actual bedside nursing. And here's some examples. So my example, I became a nurse, and I know when you're in preceptorship, it's different nowadays. When I became a nurse, it was a full 6 weeks. You had to, before you even became on your own as a nurse, you had to basically check the boxes on different things that you had to do. Like, you had to have an EKG class. You had to have obviously your BLS. You had to pass certain medications or did certain things before you hit the floor. That might be different now, but there was like a check-off list when I became a nurse. But my experience was when I hit the floor, because nursing school teaches you foundation, it really doesn't give you like actual experience of being at the bedside. So because I was so used to like medication pass, medication pass, medication pass, medication pass, that I'm in the middle of passing medications when one of my patients is having like a full-blown shortness of breath distress situation. And my preceptor was great. I think it was just because nursing school really doesn't give you that. You might get a little bit of it depending on like if you're there and you experience a cold, but it still doesn't give you like everyday real life that you get when you hit the floor. So I'm like passing my meds. I knew that I still had some 9 o'clock meds left, and it was like 10 o'clock. And I'm like passing my meds. Subconsciously, I heard the pipette like beeping, but I think I was so focused on like pass my meds, pass my meds, pass my meds, pass my meds, like 9 o'clock meds, pass my meds, that I didn't even hear. Like I heard it, but I didn't hear it. So my preceptor comes running down the hallway like, Brittany, you don't hear that noise? You don't hear that pipette going off? I'm like, no. I was passing the med. I was passing my patient med. She like, girl, this patient in here can't breathe. I'm like, oh my God, I felt so embarrassed. I felt so like, oh my God, about me, I think I'm a little bit of a perfectionist. So at that moment, I'm like beating myself up like, oh my God, you standing right, like literally I was like in the middle of rooms. She was in the room behind me, and I'm standing right there while she's in distress. But that was a learning point for me, and that's what those little things help you become the best nurse you can be. And I had a lot of experiences like that with different physicians, different NPs, different PAs that helped me see past what I was actually looking at with my patients. I can give you another example. A well-known physician at the hospital I work at, she has since passed, but very good physician. I had one of her patients, and the patient's blood pressure was high. And here I am, a new nurse, thinking, oh, I found a high blood pressure. Let me call the doctor. So I called the doctor. I'm like, hey, the 123. His blood pressure is 140 over 90. She like, okay. I said, yeah, I was calling to see if I could get an order. I'm laughing because when I think back, it's crazy. But I'm calling to see if I can get an order. She was like, okay. She started like kicking off these questions like, what was his vitals the last 2 days? What last imaging did he have? Is he on any supplemental O2? Does he have a history of high blood pressure? Like, she started like spewing out these questions that I didn't even know. I just knew when I seen the vitals, the blood pressure was high, and I immediately called the doctor. In nursing school, that's what they teach you though, right? They teach you this happens, call the doctor. This happens, call the doctor. There's really no critical thinking skills that you learn in nursing school. And that's my opinion. That's just from me being a nurse and an NP these amount of years. I just feel like it's not really real life. It doesn't give you that. So it's the things like that help me kind of molded me. So from like that situation on out, anytime I call the doctor, I have my information together. Every morning during the morning shifts before report, I would get a sheet of printer paper. I would fold it up or whatever, three folds, right? So you had technically 6 different columns. I would put pertinent things in those columns. So like get a label each of the columns, and then I would put like the pertinent tests, vitals, pertinent medications, any questions or anything that midnight shift didn't really know. Maybe I could get more answers on day shift. I had those questions. I had any questions that I thought that I needed to ask the physician to get more clarity. Any imaging, results of imaging down, so that if a physician or a family member decided to ask me questions, I had it right there. And so from that point on, I did that in the morning when I did a report. I would write certain things down that midnights may not have known or have questions about, so that way if I needed to call a doctor, I had my stuff together. If something was going on with a patient, their blood pressure was low, they had a low heart rate reading, I would sit there. If the patient was not in distress, I would sit there, I would review the vitals, I would trend the vital chart, so I would look 2, 3, 4 days, depending on when the patient was admitted. And I would look to see what the vital trends were for those days. So maybe the pressure is lower or the heart rate is lower in the morning than it is in the night. Like, I sat there and I studied that, like studied it. And then if a physician around it, and physicians and NPs and stuff, they spew out questions, I wanted to make sure I had the answers for those questions. Now if I didn't, because you can't think of everything, I at least had it enough so I could answer some and then say, hold on, let me double check that. So it wasn't like I couldn't answer anything then and look incompetent. I didn't want to do that. But those were things that I had to learn in order to grow to be a good nurse. I had to have those moments with different vet nurses, physicians that helped me grow. You take those moments and you think about them when different things come up, so it can make you a better nurse. So just keep that in mind. I also want to point out time management, because I know a lot of times, even me, I would come in, I'm talking to the night shifts, I want to get breakfast, not saying you can't eat, but you also taking care of families, and in the morning shift, your physicians and NPs and PAs are going around at a certain time, so you just want to have certain stuff together before that happens, so when they rounding, you can be on your stuff and it's not throwing you off that you gotta stop and go look up something when you got all that readily available for you. So another thing too that can be different is, back in the day, I feel like staffing was way better. So I know now you guys are handling 5 or 6 patients no aide, no tech. I totally understand that. But some of the nurses that I do encounter, the newer nurses, I feel like they're not really receptive to somebody saying, "Hey, what if you did this differently, or what if you did that differently?" I, like I said previously, I took those moments and it made me a better person. And I ask questions. I am not scared to ask questions. I ask questions. I'm pretty sure my husband hates that because I ask questions all the time. But that has gotten me to where I am today. Ask questions if you do not know. If somebody is trying to, and you know the difference for when somebody's trying to help you versus somebody trying to like down you. You could pick up when somebody really like is caring about what you're doing and want to see that change. And so you take that and you go with it. Like, for example, as a nurse practitioner, it's been many times where I have rounded and it's 1 o'clock in the afternoon and I'm looking at the patient's vitals and the patient blood pressure is like 80 over 60. And I'm like, hey, it's 1 o'clock. You took this blood pressure at 7 a.m. Do you have any more blood pressure for me? Maybe maybe you didn't get a chance to chart them. No. Okay, like, do you have any information for me about like when this pressure was low? Were they complaining of anything? I mean, I don't know. I mean, I have 6 other patients. Like, attitudes like that, you do not want to have, because you got to remember, are you trying to grow? Are you trying to be just where you are? Because if you're just trying to be where you are, that's fine. But if you're in the mentality of growing in yourself and in your practice, you got to take those moments and look at yourself and be like, okay, how could I have did this differently? Like, I knew with me, I knew that bedside was not my ceiling. I knew my ceiling was higher than that. So in different circumstances of my career, I use those moments to grow. And so when I'm talking to that nurse, she's not very receptive of me saying, well, hey, I understand you have a lot of patients. I understand. But if your patient got a low reading, you got to go in there and recheck the blood pressure yourself. That's one thing I would recommend, is if your aides are doing vital signs and they give you a low blood sugar or they give you a low reading with something, the first thing you should do is go check that yourself. Because I know that what I'm going to ask if you call me with it is, how many times did you check it? Did you check right and left arm if possible? Did the aide check it or did you check it? Not saying that the aide can't do blood pressures, but you just want to be that backup, because at the end of the day, you are the nurse that's taking care of the patient. So, if that phone call would be like, hey, Brittany, my patient in 23, 7 a.m. we came in, the blood pressure was 80 over 50, heart rate was 60, temp was 97.3, SpO2 was 95. I went in there, I took it again, the blood pressure was the same, 80 over 50. I look back, the previous blood pressures, he or she, whichever, the blood pressure normally range around 111 to over 70 to 120 over 80. So this is the first reading that I've gotten. The patient is not in distress, not complaining of any shortness of breath, chest pain, any lightheadedness. He's talking, he's learning oriented times 3. I just wanted to let you know of the low reading. That's it. Like, that's how you would do that. But if you don't address it, the provider rounds and it's like, dang, we all liable for this patient, right? If something happened to a patient, everybody that's charting on that patient is going to be pulled in a deposition. Just not the physician. You are, the physician is, the speech therapist that went and did the bedside swallow, the physical therapist that came in and did range of motion exercise. All those people are going to probably be sitting in depositions if something happens to that patient. The person who came up and did the echo, the person that came up and did the x-ray, like, all disciplinaries are at risk of being sued or in this deposition because something happened to the patient. You always have to be thinking about that. It's not about, oh, I have these 6 patients and it's overwhelming. Like, if you getting up and going to work every day, you know you gonna come in knowing that, okay, I already got this, but you still gotta set your own momentum and your own pace, because at the end of the day, you are taking care of someone else's mother, sister, brother, auntie, uncle. I mean, just keep that in mind. You know, I'm pretty sure when your loved one is in a hospital, you own it because you know what to look for. Other people don't. So keep that in mind. I understand that it is like not helpful these days. I have experienced a situation where a nurse was like drinking water at the nurse's station, and the administration, I don't even want to say which one, but she came over and was like, "You're not supposed to be drinking water at the nurse's station." And I'm thinking, like, the nurse had just told me, like, we don't have no aide. She was in charge. She like, I'm trying to find a night shift nurse because we down a night shift nurse. I got 6 patients. I ain't even hit the 6th patient yet. And did I tell you we ain't got no aide? So trust me, I do understand what is taking place nowadays. But I think that a lot of you take that and you run with it, and it's like, instead of really trying to get stuff done. I'm not saying all of y'all. Don't come for me. Don't come for me. I'm not saying all of you guys. I'm saying some of y'all use that. Instead of really doing what you're supposed to do, you use that and say like, oh, well, I have 6 patients. But it's like, if I come to the nursing station and you laughing and kikiing and talking and you back and forth, then like at some point, like, when are you gonna actually do what you're supposed to do? So, you know, just take that into the consideration. Like, and I see that bedside shift report a lot of times not being done, which, you know, I'm gonna tell you a story why I feel like it's important. Even just like, even if you reporting at the nursing station, which I know you're not supposed to, but I'm just saying, and I know it could be chaotic sometimes when you come in, but just going laying eyes on the patient before the nurse leaves, because it was a situation on us. I remember this like so clearly. It was a Sunday, and on Sundays around like, I tried around in the morning, you know, to get it out the way. So I go in this patient's room. When I tell you it's blood everywhere, like blood on the floor, it's blood on the sheets, it's blood on top towels, which means somebody seen it and put towels underneath where she was bleeding at. It was blood. I'm talking about bright red blood. The patient had just had a new colostomy put in, like I want to say a day before that. I pulled back the sheet. The colostomy is full of bright red blood. I was livid because, number one, by this time it's 10 o'clock. You took shift report at 7 a.m., which means ain't no telling how long this patient been like this. Then you couldn't do a bedside report, because if you did, both of y'all would have seen that this patient was actively bleeding and picked up the phone and called the physician. You didn't. Then when I ran out the room and I told the nurse what happened, she was just like, I didn't know, I didn't see, that wasn't there. You could definitely tell that it was there, because it was like some of the tiles were like dark, like dry blood, which means that it's old blood. She didn't even jump to like get a Dynamap to take the patient blood pressure. Like, I did that. I took the patient's blood pressure, called the surgeon on a Sunday, like, you need to take this patient back to the OR because they are actively bleeding from somewhere. She didn't even bother to call to see if she could get an order to get a CBC to check the hemoglobin. I did that. The patient hemoglobin was 4.5. The day before that, because she had recently had surgery, so it's lower, but the day before that, I think she was like at 8.5. So when was you gonna call me and tell me this patient was actively bleeding and symptomatic? I checked her pressure. The patient's pressure was 70/40. It was 10 o'clock. So stuff like that. I mean, that becomes a priority. As stated in the beginning, when I was a new nurse, the BiPAP, I ain't hear it. But I'm telling you now, I'm telling you, I'm just trying to be as helpful as I can. F them medications. If you got a patient that can't breathe, that is having any signs of distress, anything, that becomes your priority. And as with your team of nurses, they are supposed to back you up. They're supposed to help you out. What do you need me to do? Do you need any medications that need to be passed? Do you need any IV fluids that need to be hung? Do you want me to call somebody? Those are your backups. If y'all not working as a team, the shift not gonna shake right. It's just not. When I was in the ER, if all my rooms was empty and I got 5 runs, it's gonna be a nurse in each room. I'm gonna be in one room, and when I come out, all my nursing people who was on that shift, they gonna have my back. They gonna be either getting the IV and the blood work, they gonna be doing the EKG, they gonna be doing whatever they think I would need at the beginning of getting that patient. They're gonna be at least put them in for me, take their vitals. I really feel like the camaraderie of the shift is like drifting away, and that's probably because of burnout and turnover. And so I think it's not a problem with just nursing. I think it's system-wide that needs to change. And until you get that change, it's going to continue to be hard. But all I'm trying to do for you is to get you to be the best nurse you can be in the situation that you have. You can't change it. Hopefully, one day, these administration people come to their senses and try to change. But at the end of the day, it is a business too, unfortunately. So us as nurses has to think like, how can I be the best at what I can do for my patients and for myself? And so you have to look at that when you in those type of situations. I did want to stress some differences that I wrote down from nursing school to bedside nursing. So in nursing school, it's a controlled setting. You have theoretical knowledge. You observe it during clinicals. It's a pass-fail mindset. Like, if I do this, this is what I pass. That's if I don't do this right, I fail. It's not really a care mindset. And some of you guys are doing simulation practices versus your bedside nursing is going to be fast-paced, unpredictable, because you can be cool 1 minute and the next minute you got 2 colds. Or you got a patient coming back from having an angio, now they coding. The family in the room now. So now you got to try to get the family out the room, get the cold team. Like, it can be a lot. It's unpredictable. Real-time critical decisions, being the responsible nurse, life and death responsibility, and real people, real emotions. So that is the difference. That's why it could be such a shock when you cross over from nursing school to being in the bedside. I kind of felt like, dang, what did I learn in nursing school? Did I learn anything? Is it just me? Or like, that's what I thought. But as like the months and the years go on, if you really be observant and ask questions and really want to be the best nurse that you can be, that fear goes away. Like on IMCU, I think I was up there maybe 6 months. I know it was maybe a year, not at that, but maybe a year. And I think like I became charge nurse within maybe 6 months of being up there. And then, when I came down to the ER, I got pregnant, but after I came back off maternity leave, like I was determined that I wanted to learn to be the charge nurse. And so what I would do was that I would like ask the charge nurse, I'd be like, if it was like slow but not really slow, I'd be like, let me do a little bit of what you're doing. Kind of put yourself in situations to help you grow. In turn, that helps you because some people see that, some people see you. And so then when it comes time for me in my situation, when it came time for me to be like, I'm done with our NP school, like what direction am I going to go through? Because I was like shadowing a primary care doc. I knew that primary care wasn't something that I really wanted to do at the time because I was still so acute. Um, that the situation came to me. Like I was asked, being a new grad, no experience as a nurse practitioner, asked to be a hospitalist. But that was because of the work that I had put in over those 6 or 7 years, with 5 years, 5 to 6 years of being a nurse. Like the work, the relationships, and everything that I had to work on, and the work that I had to put in led me to that point. Even like the relationship that I have with physicians and nurse practitioners and PAs today, the stuff we talk about and stuff, they tell me it's because of the work and the relationship that I have slowly built over time. And, not the relationship to where it was, because I know some physicians, they like to, you want to take me out? No, because me and my husband been together since 18 and 19. So it wasn't none of that. I built relationships strictly on my work ethic. Strictly on my work ethic and, being humble and, you know, um, going to different things, networking, talking to people. You really got to take it serious. You put time, you put work into this. You lost money. If you got kids, sometimes you can't do stuff with your kids. Just think about the sacrifices that you took to be where you are today. And just start like watching people. Somebody is trying to give you advice. And I'm not saying take advice from everybody because you cannot. And I'm not saying do that. You got to discern who the person that's giving you advice is, they really trying to help you. But if you feel like they are, take it. Take it and use it, because it can definitely help you in the long run. I also wrote down some advice that I could give to you guys. The first one is, don't panic if you feel unprepared. You are not alone. You are not alone. You're not alone. Just ask questions. My next one, ask questions. Find a mentor and stay teachable. Stay learning. Even now, I stay in my webinars, I stay in my books, financial literacy books, medical books, all types of books. I stay learning. Stay learning. So don't ever let that slip. Be kind to yourself. It's a huge learning curve coming from nursing school to actual bedside nursing. Be kind to yourself. Just you mess up, as long as the patient, it didn't cause the patient any harm. Learn from that situation, because it might happen again. So don't take it and beat yourself up or whatever. Take it, process it, and learn from it, because I promise you it will make you a better nurse and a better person later on. The first 6 months are the hardest. The first is, it take time. It take time for stuff to click. It take time to combine what you learned in nursing school to real life experience. It take time to mesh that together. So be kind to yourself and just know that it's gonna be a process. But if you're willing to learn, if you're willing to be teachable, it's gonna make you a better nurse. You don't have to know everything. You just need to care and keep learning. Learning, ask questions, and be teachable. That is it. Learning, ask questions, and be teachable. If you do those things, you will fly. You will soar. And, if you guys want to talk about anything else that you feel like I missed or I didn't address, drop it in the comments. I'll talk about it. I'm going to be as real as possible, just like I'm being now. That's all I can be. But I hope you guys enjoyed this episode. Hopefully it helps you. And stay tuned for episode 3.